Morning everyone. I will be speaking on the role of metabolic imaging, the new TNM classification of lung cancer. Now, essentially by metabolic imaging, I mean PET or fluorodeoxyglucose PET scan, which is the backbone of lung cancer staging. The general outline of my talk would be the role of FDG PET in T, N, and M stage, and I would discuss each of these with clinical examples. When it comes to staging of lung cancer, why is staging important? Like any other cancer, staging is important because prognosis or outcome of the disease depends upon stage. And stage decides what is the optimal treatment which can be given for every cancer. Now if you look at this table, this shows the 5-year survival for lung cancer. As we move from stage T1A to T4, you can see that the survival, which is upwards of 90% for T1A, drops down to less than 50% for T4 cancers. Likewise for nodal status, for N0 Sahara, which is about disease, survival, which is about a year for M1A, drops to less than 6 months for M1C. So you can see that it's the stage which decides the outcome. If you look at the NCCN guidelines, it recommends the use of FDG PET-CT across all stages, and it is really a standard of care imaging modality for lung cancer. When it comes to cancer staging, currently we are following the 8th edition. But to understand the current 8th edition, we need to understand what the 7th edition was all about. Now, this is a table which shows T staging of lung cancer, which was described in the 7th edition. You can see that essentially T staging is based on size criteria. There are different size cutoffs for T1, T2, T3 and T4. Now, when it comes to the new TNM staging or 8th edition of TNM, there are a few variations which are again based on size. For example, T1, which was just A and B for 7th edition, is now become T1A, B and C, and so on and so forth. T stage depends upon size and what the tumor does to the surrounding structures like the chest wall, diaphragm, blood vessels, etc. Cancer, about 3 centimeter size nodule surrounded by lung of pleura. CT scan is good enough to determine the stage in this particular case. This is the PET CT scan of the same patient. Now here you can see that FDG PET theory does not add any additional value. Similarly for E3 stage, you can see that this is a tumor which is infiltrating the mediastinal pleura, and is the mediastinal factor here. This is T3 stage. CT scan tells you everything. This is the PET CT of the same patient. Again, PET doesn't add any incremental value. Coming to stage T4, these are 2 examples of T4 lung cancer. Here's a tumor encasing the left main pulmonary artery completely, whereas this one encases the aorta as well as causes erosion of the vertebra. So these are 2 examples of T4. Again, their PET CT scans show exactly the same thing, do not add any much incremental benefit. So for T staging, the modality of choice is a CECT of the chest. If PET CT is done with the use of contrast, it provides similar information. Chest radiographs are of limited value, though they can provide some information. MRI is usually not a preferred modality except for pancreas tumors. So, what is the role of FDG PET-CT in T stage? This is an example of collapse consolidation of the upper lobe here, probably by a centrally situated mass causing cutoff of the left upper lobe bronchus. You can't see the tumor very clearly. This is the PET CT, and PET CT tells you clearly where is the tumor, and it can differentiate the tumor from surrounding consolidation. So PET for T stage is useful for demarcating tumor from surrounding atelectasis. Occasionally it can help you determine whether the tumor is just abutting the chest wall or it is infiltrating the chest wall. As for example in this case, here the tumor abuts the chest wall. There is, you can see on the FDG PET that there is this atelectatic change here, and the tumor actually is not abutting or infiltrating the chest wall. So these are occasional examples where FDG PET can be useful for staging. Coming to nodal staging, between the 7th and the 8th edition there is no change. Nodal staging is based on the location of nodes in relation to the primary tumor. N1 nodes are ipsilateral, hilar, lobar, interlobar, segmental. N2 nodes are ipsilateral mediastinal nodes. Generally for N1 and N2 disease, the treatment is surgical in most cases, whereas if the nodes are contralateral, mediastinal, hilar, or supraclavicular, then it's N3, and usually the treatment is non-surgical. So when you look at historical data and meta-analysis which compare CT versus PET in lung cancer, you can see that PET CT has higher sensitivity as well as specificity compared to CT scan. And this is because of the inability of CT to detect disease in small sub-centimeter size lymph nodes. CT uses a cutoff of centimeter, whereas CT can also pick up larger nodes which are inflammatory in nature. Now, this is the conventional teaching or wisdom in Western literature. Coming to Indian setting, it can CT, the advantage of FDG PET CT are a little bit minimized because of detection of false positive lymph nodes as well. So this is an example of a lung cancer here on the left side. This is small mediastinal lymph node, less than a centimeter in size, which would be called as negative by CT criteria, but shows intense uptake on PET. And this node on mediastinoscopy was positive. So this is CT negative, but PET was positive. So this shows that PET has a higher sensitivity than CT scan. If you compare the role of PET for nodal staging across various countries, you can see that the negative predictive value of PET for mediastinal nodal disease is high, whereas the positive predictive value is quite modest. And we looked at our own data, the negative predictive value was equally high, but the positive predictive value was around 53%, which tells us that PET has false positives and it can't really differentiate metastatic from granulomatous mediastinal lymph nodes. So this is an example of a lung cancer with this extensive mediastinal lymphadenopathy. This is another example of lung cancer with FDG mediastinal lymph nodes. Now one of them is TB and one is cancer. It's very difficult to determine which one is tuberculosis and which is cancer. This one was cancer, whereas these FDG mediastinal nodes was tuberculosis. For nodal disease, TB or not TB, false positive PET remains a challenge. If there is a positive PET, then invasive staging was required by EBUS or mediastinoscopy. If the PET is negative, this has a high negative predictive value. The current practice in our institute or in most centers is still to do mediastinal staging. Now for M staging, for the current edition, the M staging has been split into M1A, M1B and M1C. So M1A is mainly intrathoracic metastases, which could be contralateral lung nodules, pleural or pericardial effusion, whereas M1B is a single site of extrathoracic mets, whereas M1C is disseminated extrathoracic metastases. For M1A, CT scan is good enough, and for M1B and C, there are several modalities like bone scan, PET CT and MRI brain, but a combination of PET and MRI brain covers up all sites of extrathoracic metastatic disease. And when the patient is M1B or M1C, it's usually systemic therapy which is offered. So for metastatic disease, PET really makes an impact. There have been a few randomized trials which have looked at the ability of PET to prevent futile thoracotomies in early operable lung cancer. You can see that nearly 20% of patients, when PET scan can prevent futile thoracotomies in a randomized trial setting, when PET scan was used to stage disease in one arm, whereas in other arm, conventional workup was used to stage the disease. So when PET is added to the diagnostic algorithm, now 20% of patients' futile thoracotomies are prevented, and this is because of detection of subtle, silent metastatic, distant metastatic disease. This is an example of a lung cancer here. Looks operable. On CT scan there is no obvious metastases, but on PET you can see that there is this peritoneal disease. So T2N0M0, which can be operable, now becomes T2N0M1. It is inoperable and needs systemic chemotherapy. Another example of a centrally situated lung mass here, PET-CT detects these certain sites of metastases to the chest wall and also in the bones. You can see PET in the pubic bone, and this makes it M1 inoperable. PET can be used to characterize certain small pleural effusion. An example for lung cancer with a small thin film of fluid, which is often reported as reactive pleural effusion, and so TAPs are very often negative, but occasionally in PET, when you do a PET scan, it is useful in detecting these certain sites of pleural metastases which have given rise to pleural effusion, so this patient becomes M1A. For brain metastases, MRI obviously is superior to CT. MRI is superior to PET, and thus MRI retains that superiority when PET is combined with CT. Negative PET-CT does not obviate the need for dedicated brain imaging at MRI. That's something which we need to remember. This is an example of brain metastases in the brainstem here. PET shows no uptake. So this is the reason why MRI is relied upon and not PET-CT. That doesn't mean that all brain mets are missed. Sometimes PET does pick up brain metastases as seen in this particular case. So to summarize, FDG PET has an established for staging of lung cancer, and its most effective value is for M staging. Though for brain metastases, MRI is still preferred. For nodal staging, it is marginally better than CT, but it's still you need to confirm with histology PET positive lymph nodes. For T staging, there is usually no additional value except in some situations which I mentioned, like demarcating tumor from atelectasis, etc. And PET is recommended by all guidelines for staging of lung cancer. Thank you for your attention.